Bismillahirrahmanirrahim. Today in this lecture we will discuss the foreign body's airways. Foreign body airways is an emergency in majority of the patients, especially in children. The foreign body airways can lodge in different sites and it will depend upon the size of the foreign body, nature of the foreign body. It may lodge in the larynx, trachea, or bronchi. This is the pie graph showing you the incidence of lodgement of foreign body in the airway. You can see that the right main bronchus is the most commonly affected site, where around about 50% of the foreign bodies can lodge. On the other hand, the second to this right main bronchus is the left main bronchus, which accounts for 20%, and the trachea is responsible for 15% of the lodgement of foreign body in the airway. If the size of the foreign body is larger one, then it will be unable to pass the glottis and it will lodge in the supraglottic area. If foreign bodies are smaller in size, then they will pass down through the larynx into the trachea or bronchi. And it is also important to note that right main bronchus is more oftenly affected as compared to the left one because it is wider and more in line with the trachea. The sharp foreign bodies, for example, pins, fish bones, needles, they may stick anywhere in the larynx or tracheobronchial tree. Now, this figure will give you some idea why the foreign bodies they are more common in right main bronchus. The reasons are: number one, the diameter of the right main bronchus is larger as compared to the left main bronchus. Secondly, the angle of divergence from the tracheal axis is smaller on the right side, and airflow through the right lung is greater as compared to the left one, and the carina is more likely to be located to the left of the midline rather than to the right. So these are the some of the facts which are responsible why the foreign bodies are more oftenly seen lodged in the right main bronchus. Etiology. First of all, the age. No age is immune to foreign body airway. However, children are more commonly affected. It has been seen that more than half of them are below 4 years of age. Foreign bodies are aspirated by the children suddenly when they inspire during play or fight while they have something in the mouth. For example, plastic whistle. Anyhow, in adults, the foreign bodies are aspirated during coma, deep sleep, or alcoholic intoxication. Sometimes loose teeth or dentures may be aspirated during anesthesia. Second, apart from age, nature of the foreign body is also important. For example, the inhaled or aspirated foreign body may be irritating or non-irritating. The non-irritating foreign bodies, they remain symptomless for a long time, for example, plastic, glass, or metallic foreign bodies. The irritating foreign bodies, especially the vegetable foreign bodies, they set up a diffuse violent reaction at the site of lodgement and lead to congestion and edema of the tracheobronchial mucosa, so-called vegetable bronchitis. They also swell up with the passage of time, causing airway obstruction and later suppuration in the lung. Examples of vegetable foreign bodies are peanuts, beans, and seeds of different kinds. Clinical features of foreign body airways. Clinical features can be divided into three stages. Number one is initial period of choking, gagging, and wheezing. Secondly, symptom-less interval. And third, late symptoms. First, the initial period of choking, gagging, and wheezing. This period lasts for a short time. Foreign body may be coughed out or it may lodge in the larynx or tracheobronchial tree depending upon the size of the foreign body. Second is the symptom-less interval. The respiratory mucosa adapts to the presence of foreign body and initial symptoms disappear. The symptom-less interval will vary with the size and nature of the foreign body. The third stage is the late symptoms. The late symptoms are caused by airway obstruction, inflammation, or trauma induced by the foreign body. The symptoms will be according to the site of the lodgement. For example, first one is the laryngeal foreign body. If the foreign body is a large one, it may totally obstruct the airway, leading to sudden death unless resuscitative measures are taken urgently. On the other hand, if foreign body is a small one, it will cause partial obstruction. So it may produce discomfort or pain in the throat. It may cause hoarseness, whooping cough, aphonia, dyspnea, wheezing, and hemoptysis. If the foreign body is lodged in the trachea, in that case, if the foreign body is sharp, it will cause cough due to irritation and sometimes hemoptysis. If the foreign body is a small and loose, it will move up and down within the trachea between carina and undersurface of the vocal cords, causing audible slap. Sometimes wheezing may be heard as well. Bronchial foreign body. Most foreign bodies enter the right main bronchus as compared to the left one bronchus because it is wider and more in line with the tracheal lumen, as I have already discussed. A bronchial foreign body will produce symptoms according to the type of the obstruction. First, partial obstruction. Air can pass in and out. It will cause only wheeze. Second, one-way obstruction. Air can go in during inspiration but not out during expiration. It will cause emphysema of the lung. Total obstruction. In this case, air can neither go in nor out. It will cause obstructive atelectasis, lung collapse. The patient will have decreased chest movements and decreased air entry on the affected side of the chest. X-rays chest will be confirmatory, showing collapse of the lung on the affected side. The last one is the one-way obstruction, that is reverse of above mentioned one-way obstruction. In this case, air can go out only. It will cause atelectasis. Now this is the figure showing you all these mechanisms of airway obstruction by the foreign body. Possible consequences of bronchial obstruction in case of ingress of air is there and there is also egress of air. What will happen in this case? There will be wheezes. This is the bronchial foreign body showing you check valve type obstruction. There is ingress of air only. There is no egress of air. The egress is stopped. In this way, there will be hyperinflation. And in this case, when there is total obstruction of the bronchial bronchi, causing stop valve obstruction, that in this case, there will be no ingress and no egress. So the patient will have atelectasis on the affected side. Diagnosis. Number one is the history of aspiration of foreign body with initial period of choking, gagging, and wheezing. This is very, very important to ask about these clinical features from the patient or from the attendant of the patient. Second, physical examination of the neck, chest in details, and then radiological investigations, which are very, very helpful to diagnose the condition. The radiological investigations are, for example, X-ray soft tissue neck, posto-anterior view and lateral view in external position, radio opaque and even sometimes radiolucent foreign bodies in the larynx and trachea may be seen. Second, X-ray chest, PA view and lateral view for foreign body bronchus. X-ray chest at the end of inspiration and expiration. It will be helpful to see atelectasis, obstructive emphysema, and sometimes indirect evidence of radiolucent foreign bodies. Then fluoroscopy or video fluoroscopy during inspiration and expiration. Similarly, bronchograms to find out radiolucent foreign bodies due to filling defect or to evaluate the bronchiectasis. 3D scan of the neck and chest, axial and coronal views. Similarly, diagnostic bronchoscopy, which will help you to diagnose the condition. Management. It will depend upon the site of the low limit. First, laryngeal foreign body. If a large foreign body obstructing the airways just above the vocal cords, then the patient will be in dire emergency. He will be aphonic and may die of asphyxia unless immediate first aid measures are taken. These include turning the patient upside down, secondly, pounding on the back, and third, Heimlich's maneuver. This Heimlich's maneuver is very important to understand. What is Heimlich's maneuver? The steps of Heimlich's maneuver are: number one, step one is first lean the person forward slightly and stand behind the patient. Second, make a fist with one hand. Third, put your arms around the person or the patient and grasp your fist with your other hand near the top of the stomach, just below the center of the rib cage. And the fourth, make a quick hand movement inward and upward so that the foreign body may be cuffed out by the patient. If the laryngeal foreign body is causing partial obstruction, then these all measures are contraindicated because partial obstruction may be converted into a complete obstruction, leading to sudden asphyxia and death of the patient. Therefore, in such a patient where there is partial obstruction, all these measures they are contraindicated. If Heimlich's maneuver fails, then cricothyrotomy or emergency tracheostomy is done to relieve acute respiratory obstruction and to relieve and to save the life of the patient. The fourth one is direct laryngoscopy and removal of the foreign body. And fifth, if foreign body is impacted, in that case, first perform laryngofission and then remove the foreign body. from the larynx. Then, if the foreign body has been lodged in the trachea or in the bronchial tree, then usually these are removed with full preparation under general anesthesia. These are removed in emergency only if the foreign body is causing airway obstruction or foreign body is vegetable in origin, for example, seeds, which are likely to swell up with passage of time. This swelling of the foreign body will make its removal difficult. Methods to remove the tracheobronchial foreign body. Number one, conventional rigid bronchoscopy and removal of the foreign body. Second, rigid bronchoscopy with telescopic aid. Third, bronchoscopy with fluoroscopy. Fourth, use of Dormio basket or rounded foreign body. And fifth, tracheostomy first and then bronchoscopy through the tracheostome and removal of the foreign body. Sixth, thoracotomy and bronchotomy for peripheral foreign bodies. And the last one is the flexible fiber optic bronchoscopy and removal of the foreign body in adults. Complications of foreign body. Complications of the foreign body depend upon site of lodgement of the foreign body. Second, nature of the foreign body. Because foreign bodies of vegetable origin, they are more dangerous to cause complications as compared to non-irritating or non-vegetable foreign bodies. Complications of the foreign bodies of the larynx and trachea up to carina. They, these foreign bodies, they may cause respiratory obstruction, choking, and death of the patient. If the foreign body is lodged in the bronchi, major bronchi, or distal to the main bronchi, then they may cause lung collapse, emphysema, bronchitis, bronchiectasis, and then sepsis. This is the foreign body in the right main bronchus. You can see a sort of hairpin has been aspirated by the patient and it has been lodged in the some part is present in the trachea and the distal part of the so-called hairpin is in the right main bronchus. This is another foreign body in the right main bronchus. In the This is another foreign body, the same foreign body in the airway, in the lateral view of the chest. This is a nail which has been aspirated by the patient in the trachea, and you can see that there is atelectasis, or you can see the foreign body which has caused the collapse of the lung. Another foreign body which has been aspirated by the patient and some part is present in the trachea and the distal part is in the right main bronchus. This is again seems to be a nail in aspirated by the patient. A nail has been aspirated by the patient. This is the esophagus which has been shown by X-ray Bayesian swallow and which shows that this foreign body is outside the esophagus. That is, it is in the airway. Now, this is the photograph showing Dormia basket removal of the foreign body from the trachea near the carina. This is the Dormia basket removal, foreign body removed after performing the fiber optic bronchoscopy in adults. Similarly, this is a foreign body which has been grasped by the top forceps after performing the rigid bronchoscopy. This is the rigid bronchoscope showing the penetrations for ventilation. Thank you very much.